Good afternoon. I'm Jana Martin, Chief Executive Officer of the American Insurance Trust, known to most of you simply as the Trust. We are delighted that you're able to join us virtually today for the first webinar in our new virtual webinar series. The Trust is pleased to be able to offer this type of informative content free of charge to our policyholders. Make sure you block time in your schedule for our next event, a telehealth community chat on Monday, April 27th at 5 p.m. Eastern Time with Drs. Sarah Smucker-Barnwell and Margot Adams-Larson. I also want to remind you of the COVID-19 resources page we've put together, where you'll find resources created by the Trust and our partners. We'll continue to post updated content as it becomes available. You can find a link to this page as well as the virtual webinar series page on the important information slide. Here at the Trust, we live by our motto, for psychologists, by psychologists. It resonates in everything we do, and we pride ourselves on being able to support the profession of psychology in ways no one else can. Most of you are likely familiar with our risk management consultation service, the Advocate 800 program. It's one of the many benefits our policyholders receive through the Trust. 3 of our advocates are with us today, Drs. Joe Scropo, Julie Jacobs, and Liesl Bryant. In the interest of time, we've placed their bios on a slide for you. A special note, it would not be a good presentation on risk management and telehealth if we didn't demonstrate anticipation of some surprises. We have just found out that at some point during the presentation, Dr. Julie Jacobs may just disappear. She may leave the call because of a power outage that is planned in her area due to storm activity. We're prepared for this possibility, and we want you to be too. In that event, Dr. Bryant and Dr. Scropo will take over, and I'll present the questions. Before they begin the presentation, I have a few additional things to tell you. First, we hope this will go just as smoothly as our previous live stream webinars, but should there be a technical problem, please bear with us. We'll do our best to keep things moving. If you do happen to run into any issues that you're unable to resolve after using the instructions provided at registration, contact our web streaming provider, Beacon Live, at their help desk at 800-747-1719 or send them an email at support@beaconlive.com. As this is an interactive webinar, we will be taking questions from participants. Please look for the question and answer box and type in your questions. Our team will do their best to answer as many questions as possible. Unfortunately, as is true in most any presentation, we will not be able to get to all of your questions. This virtual webinar will earn you 1 CE credit. This can be combined with other risk management credits to save 15% on your trust-sponsored professional liability insurance policy. Please remember to submit your CE certificates with your policy renewal. Check the information that we provided to find out how you can obtain additional credits. Again, I hope everyone learns a lot over the next hour. Please join me in welcoming our esteemed presenters. Dr. Bryant?
Great, thank you, Jana, and welcome to everyone who is joining us. I want to just add to one thing that Jana said in terms of we are going to try to get to as many questions as we can, but I also want to keep in mind that sometimes there are state-specific requirements or things like that that need to be considered, or also just specifics to the case that we may not be able to address all the nuances and particulars. And in that case, if either your question doesn't get answered because we run out of time, or if there are specifics to your state regulations or a particular case, we really just encourage you, for those of you who are entrusted insureds, you can give a call into the risk management line and talk with any one of us about whatever the case is. So, okay, on that note, we are just going to dive right in so that we can get going. The first question is, can or should I continue to see patients in person? And if so, what should I consider in making this decision? And Julie, why don't we start with you?
Sure. That's a great question, and obviously one that many people have been asking lately. It depends on a number of things. I mean, obviously, the first criteria, or the first thing to consider is the legal or regulatory regime in your state. Most states have stay-at-home orders. Most of them also have outlined what essential businesses are, and in most cases, healthcare is considered essential. So technically, from a legal standpoint, you may be permitted to see people in person, but there are other things to consider. There's the ethical considerations of putting yourself at risk, putting your clients at risk, of asking people to leave their offices or leave their homes when perhaps it's not safe to do so. And you know, you need to consider, if you were to want to see people in person, do you have an office that's set up appropriately so that you could maintain the appropriate distances, that you could maintain, you know, have hand sanitizer, have all the precautions in place that you would need to in order to minimize the risk of harm to people. It also is going to depend in part on where you are. You know, in my state, in Colorado, we're not nearly as high. We don't have as high a rate of infection or issues right now as they do in other states, and so there may be some considerations in terms of your actual location. There is no requirement, or I can't think of a situation where you must see someone in person. There are usually other options if you have telephone or teletherapy options, or even crisis management or hospitalization if it's necessary. So that's kind of a quick way to run through it. Joe, you may have some other ideas. It's a pretty complex issue.
It is complex, and it does depend a little bit on what region of the country you're in and how much sheltering is going on there. But as Julie said, the key thing is that you don't have to see. There's no mandate to see people face to face, and there's good reason not to. The risk of further communicating the virus and the difficulty of knowing whether you've been able to sanitize and prevent any transmission. That's a heavy burden to take on if you do see people face to face, to be able to offer those kind of assurances. So I would be very careful about doing it, meeting with people face to face. And like Julie said, I don't think there's any mandate that I can think of that would require you to do so, especially when there's other methods that you can use, like phone or video, to connect with your patients.
Great. And sort of in the other direction, we have another question that says, I'm uncomfortable returning to in-person sessions with patients once the shelter-in-place orders are lifted. What criteria should I use to decide when we can safely resume in-person patients? Joe, do you want to start that one?
Sure. I think it's a personal decision, ultimately. I mean, you are, if you do bring people into your office, you're obviously going to increase the risk of some transmission. And I think it's ultimately up to you to decide when you feel that it's safe enough, with precautions that you may put in place, like the 6 feet or more distancing, disinfecting your office, and so on. So I think it's a personal decision as to where that point is. And you have some leeway. I think you can continue using video and phone until you feel that you're ready to start moving back.
Yeah, I agree with that, and I just want to throw in one other consideration. You know, if you're feeling anxious about it, don't feel pressure to do it until you're ready, because it can impair your competence, and it can impair your ability to be effective as a therapist if you're so anxious about the fact that you're even there and you're bringing other people into the office. So give yourself permission to do what's comfortable for you, and to not feel pressure from others to take an action that doesn't feel right and that might impair your ability to do the best work you can.
Great. Okay, we're getting a bunch of questions also on insurance reimbursement. So one question related to telehealth first, do we need to notify or consult with the trust as our insurer if we added telehealth to our practice? Joe?
To the best of my understanding, no. Your policy and ultimately coverage questions are answered by the coverage department. So you can call customer service and ask specifically, but my understanding is your policy covers you for anything that involves the practice of psychology, and that's broadly defined in the policy. So as long as you're practicing psychology, you're insured against board defense, malpractice suits, and other risks that your policy provides against. The only thing your policy does not protect you against is criminal complaints, which are very unlikely, but there's a context in which if you video or phone into another state, there's some fairly minimal possibility, but still a possibility that under some circumstances that state could come after you to try to prosecute you for not practicing, without a license there. That's very unlikely, but if it did happen, the insurance would not be present a defense for you. No insurance company can insure against criminal risks.
Great.
I have nothing to add.
Great. And so talk just a little bit about, there's some questions about billing for telehealth. How do you code it, about the GT versus the 95 as a modifier code? When do you know which one to use?
Yeah, so the only way to really know for sure which one to use is to check with the insurance company. I think that the 95 modifier is more common right now with private insurers, but I know there is a little bit of variety out there. And so the only way to be absolutely sure is to check with your specific insurer that you're concerned about and check to see which modifier is going to be appropriate.
It comes down to two coding issues. One is the place of service on your form, and the second one is whether you add a modifier to the regular CPT code to identify that as being delivered via telemeans. So those are the two variables in coding. And Medicare, if you're a Medicare provider, wants you to use 11 for the place of service code and no modifier for the CPT code. So that's Medicare. For commercial insurance, it's best to check with the individual insurance company. It's probably going to be either place of service 02, meaning telehealth, or place of service 11, meaning your office. And there may be a modifier, 95 or GT are the two modifiers after the CPT code that indicate teletherapy. So as Julie said, best to check with the insurance company and find out which coding system they're using.
Great. And here's a related follow-up question, and you may not have a specific answer to this, so that it may be more of what do we do when we don't know kind of a question. But the individual says, I am providing psychotherapy services by telephone. When I called one third-party payer, they suggested I use the code for telehealth, which is audio-visual platform. When I explained that this code is not appropriate for phone-only consultation, they have no response. Any suggestions on how to deal with this type of issue?
Yeah, go ahead, Julie.
No, I was just going to say calling the insurer is really the best way you can manage it. And it is, of course, frustrating when you get either incomplete or inconsistent information. I think you do the best you can. You ask the question. If you get a response from an insurance rep, great, then you follow that guidance. If they're not clear, I mean, we certainly don't want to be misrepresenting the services that you're providing. If the option is, if they direct you to do a telehealth and you realize that it's not audio video and you try to explain that to them and they still either don't respond or tell you to use that code, you make a good faith effort to comply with what they're telling you. But it can be tricky, and this is such a dynamic situation that I think a lot of times the folks who answer the phone may not actually know what the answer is today because new guidance may have come out, new policies may have come out, so it can be a difficult one.
Yeah, this is just a continually evolving situation for the government, for the insurers, for us, and things are changing. So it's hard to give definitive answers. But one answer to your question is that where I practice in New York, telehealth has been broadened by executive order to include phone. So the definition of teleservice or telepsychology in New York for the duration of this crisis will include the use of phone. So telehealth code would be appropriate in New York for phone sessions, because, as I said, the definition of telehealth has been broadened. That might be the case where you're at, but the best way to do it is to find out from the insurance company.
Great. And again, just to stay on the theme of insurance and reimbursement, another question: does insurance coverage for clinical practicum supervisors extend to telehealth work with clients who are out of state or out of the country of the practitioner's license? Julie, you want to start with that?
That's another really hard one to answer. I don't think we don't have a lot of guidance about the supervision piece of this overall. I think not just for reimbursement, but in general. What is supervision permitted? You know, is do these waivers that apply to licensure apply to non-licensed people who are seeking supervision? And I know this is going to be an unsatisfying answer that we return to a lot, but oftentimes it really is just a matter of checking with the insurance company and also trying to stay on top of the different executive orders that are coming out in each state, which is easier said than done, and sometimes they can be pretty hard to digest and actually interpret. But you want to know what your state is putting out there and what kind of waivers and options there might be as best you can. Your state association may help with some guidance, and some of the state boards are putting out guidance as well.
Right. So if you have a patient that's in another state now that has relocated temporarily because of the COVID virus, and you want to find out whether you can practice through telehealth because in that state where the patient is now at, one way to find out is to look at that state's waivers, and you can go on their psychology board websites and look and see if there's been a waiver that would allow out-of-state psychologists to temporarily keep up with their patients who are now located in a state where the psychologist is not licensed. So many states have issued waivers to allow that for the time being. Where it gets complicated is knowing whether that waiver applies to trainees. When it exists, it clearly does apply to licensed persons, but it varies by state to whether a trainee would also be covered under that. Let me suggest that there are no good answers to some of these questions. So the overall approach would be to document the rationale on both sides of the question. That if I don't allow my trainee to do this teletherapy, there may be no one to do this teletherapy with this patient who's now in another state. So there's that, and there's the regulatory risk, the regulatory issue that we're not sure that the trainee can actually do this. And you in your notes would illustrate both sides of those and try to come to a rational decision about what you're going to do and try to protect the privacy and protect the therapy as much as possible and write your conclusion. So even if you're wrong, you've at least articulated your rationale and that you're aware of what was going on and did your best to minimize the harms, all the harms that could occur.
Great. Thank you, Joe. And I think there's a lot of questions we're not going to be able to answer with, fixed answers. Okay, so another insurance question, and then I'm going to switch to some other topics too. But it says, after the pandemic, if insurance does not continue to cover for telehealth sessions, but I have long distance, I think he means here long distance relationships may be already established, will I be able to convince insurance to continue to pay for telehealth for those clients?
That's a really good question. Yeah, I mean, I don't, that's, in some situations that may come down to state law and advocating for state the divisions of insurance to require parity for telehealth sessions. I'm not sure you will be able to convince an insurance company on your own as an individual to make a change like that. There tends to be a little more power in numbers if you can get some advocacy either at the state level or even APA sometimes can help push advocacy. But a little conjecture on my part, but I think that once we move so far into the telehealth world like we're doing right now, it's going to be hard to unring that bell. It's going to be hard to take away some of those benefits, or at least it might be harder. So we may find that one bright spot in this whole situation may be that there is going to be increased coverage for these more flexible modes of therapy and delivering services.
Yeah, I would say that there's the pre-COVID situation for teletherapy. That's what existed prior to this crisis. A large number of states have passed laws that made teletherapy the equivalent of face-to-face sessions and required insurance companies to treat them as such. Not all states did that pre-COVID, but a large number did. Now there's the COVID situation, and so there are all these temporary regulations. Once those are over, it presumably will revert back to where teletherapy was pre-COVID, and that would depend on which state you were in. As I said, many states do require that insurance companies treat video, or mostly video sessions, as the equivalent of face-to-face. So presumably that is going to continue where that law exists.
Yeah, and one thing before we jump on to the next question, I'll just add there too. I think it's important because none of us really know some of these answers. It's important to also just let your clients know that, right? So if you've got a client whose insurance coverage may not continue after the pandemic, you should let them know that we just don't know what's going to happen with that, and sort of raise that as an issue that you guys are going to have to address together. So I think it's important to keep passing on that information as well. Okay, so we're going to move away, at least temporarily, from the insurance piece and ask some other things just related to telehealth in general. So here's a question: can a patient use a telehealth platform while they are outside their house? In particular, this is being done because it is the best private place. And Julie, do you want to jump in there?
Yeah, I think absolutely. I mean, what's important is that it is a private place. And if inside the home is not a private place because you're sheltering in place and you've got kids and spouses and partners running around, you know, it's not unheard of to go to another place that might be more private. There's no requirement that I'm aware of that the person be in their home. And what we always suggest is giving the client the, information in advance, letting them know that it is important that they have a secure, confidential environment where they can feel free to speak as freely as they need to. And sometimes that's somewhere in their home. Sometimes that's going outside and sitting in the vehicle. It just kind of depends. You don't want them in a public place. Going to a coffee house instead of being in your home. Well, okay, these days that might be a good place because they're all closed and no one's there. But as a general rule, we don't want to go to a place that's going to be public and that's going to have other folks who can hear and see what's going on. But yeah, I think the important consideration is, where does the client feel safe and secure and like they can speak about confidential matters without being overheard, or sometimes being at risk if there's a reason for someone in the home not wanting to, if them not wanting someone else in their home to know that they're in therapy, they may need to go to another location.
Right. Yeah, and I think that this gets to some of the nuts and bolts of doing teletherapy, which we're all kind of learning, or many of us are learning on the fly. And some of the concrete elements of it are that when you do make the connection with the patient via the platform, that you ask some initial questions. So where is the patient? You want to know, and you document where the patient is, preferably a precise address, so that if you have to get services to that person, you'll know where to direct parties to go. You also want to assess the environment. Is the person alone? Is there anybody that can hear them, or is anybody trying to influence them or coach them in some way? So each time that you hook up through the video, you want to go through that, or through the phone, you want to go through those set of questions. You also want to get a phone number where you can contact that patient in the event you get disconnected or there's some kind of emergency. So each time that you start the session, you would go through these and make note of each of these factors.
Great. And so related to that, here's a question: should I be having clients sign a separate consent form for telehealth services in addition to the consents that have already been signed for in-person outpatient psychotherapy? Joe?
Yeah, I mean, informed consent is one of the most powerful protective mechanisms that we have as psychologists, and you certainly don't want to forego its use. We would suggest that you have a regular informed consent, the one that you use, that's your standard one, and that you supplement it for teletherapy with a teletherapy informed consent. And you can get both of those forms on our website at trustinsurance.com under resources and document library. There are other places that have teletherapy specific informed consents. I think ours is very good. Julie designed it. It covers many of the contingencies that you wouldn't really think of in advance, like what happens if we get disconnected in the middle of a session. What are we going to do? So both informed consents, I think, should be used together. And you want to make sure that you use a good teletherapy informed consent that addresses a lot of the kinds of things that are going to come up uniquely in teletherapy.
And the only thing I'd add to that is make sure that you're aware of your own state's laws and policies on teletherapy. Some states have outlined some specific things that need to be included in that informed consent. And we certainly did the best we could to meet those standards with the sample, but it's up to you, to each of you, to be aware of what's going on in your state. And if there are certain statements or information that needs to be included to that, you'd want to add that to the template that we provided or to whatever form you're using.
Great. And another question, is it okay to see new patients via telepsychology? Julie, you want to start on that?
Yeah, I think if we're talking about folks in the state where you're licensed, and if you feel like you can establish that relationship within accepted standards, I think it can be acceptable. I mean, you want to think about your ways of screening folks and conducting the intake, getting the paperwork to them, ensuring that they are in a location, that you are able to practice in that state, that they're in your state and they're not traveling around. You want to make sure that you have a way to verify their identity. It's not like it's somebody that you know as an ongoing patient. So you might need to have a look at their ID, have them transmit a copy of that to you, or somehow verify their identity, make sure they're not a minor. And if they are a minor, that you're getting consent from the parents if needed. And also, this is another, broken record, but some states do have requirements regarding this. So you want to be sure that if your state requires a face-to-face session initially, that you're aware of that. And then if you have to vary from that, if you're in a situation where someone needs services and they're not established with anyone else and you feel like you can appropriately provide those services, but you're not able to have that face-to-face session that's required in your state, there is some risk there. Document why you're doing what you're doing. Document why you're deviating from what you understand to be the rules, that these are extenuating circumstances and you felt that it was important to provide services to the person. And then engage in your normal standard intake process and informed consent process.
Right. Yeah, I would just add that there's really there's two basic issues when you do teletherapy. One is the regulatory issue. What are the rules for this process? Are there any laws, regulations that are relevant? And am I in compliance with them? So that's the regulatory prong. The second one is the clinical concerns. In the situation of taking on a new patient via teletherapy, assuming the regulatory issue is not in the picture here, you'd want to have the same clinical concerns you would with any face-to-face patient. Is this person suitable for teletherapy? Are they technologically capable of engaging in video or phone therapy? Are they emotionally stable enough to participate in this way and attend to some of the unique elements of having never met somebody physically, which Julie was alluding to, which would include verifying their identity by having them provide some form of copy of their driver's license or something else that they can email or fax to you. So there are some things that are unique in a way to the starting out face-to-face, but many of the concerns, I think, are the same as the clinical concerns you'd have with a new patient in your office.
Great. So what about then the question of psychological assessment via telehealth? And specifically here, there's a question about forensic assessment. Can forensic assessment be done virtually, and what should be considered there? Joe, do you want to jump in here?
Yeah, this is an issue I think that's rippling through the forensic practitioner world right now. Is what do I do? How do I see cases when there's a court order or there's a legal contract or I've been retained to do a case, and yet I can't meet face-to-face, or it's really problematic to meet face-to-face. So the question would be, can I use teletherapy to do the forensic evaluation? And I think it's going to be much more challenging for that. There are a lot more threats to validity in a forensic context. So it's the issues that you'd have to address are, for example, can I give testing and maintain its security by remote technology? So what seems clear is that PAR and Pearson and the other folks who publish tests have a platform that allows clients to take the tests at their own location remotely. And that's been in existence for quite some time. So if the tests you need to give them are on that platform, they can remotely take the test. But combined with that, you're going to need to be able to observe them taking the test to make sure that there's no coaching or that they're not looking up answers on the internet. So you would need to also have a way to monitor them taking the test, which could be done via a video camera or a proctor in the room or somebody nearby the person. But clearly it's a lot more challenging, and you have to anticipate being challenged in court to someone to say, hey, is that video evaluation really the equivalent of a face-to-face evaluation? And I think if you're going to do them remotely, you're going to have to be able to answer that question. Is it equivalent? Is there any data, any research to show that equivalence? And you're going to have to note the limitations in your report that are going to derive from the data you've lost because of having only video connection with the person.
Yeah, I agree with that completely. And, with forensic evaluations, there tend to be high consequences, so they're high risk in general. And so it might be a situation where if there's some way to put it off and postpone it, if it's reasonable to do that, that's maybe a better option. But, we will do the best we can with what we have.
One thing to be careful of is non-standardized administrations. We've gotten a bunch of calls about, is it okay if I read the questions to the person on the video or on the phone and circle their answers myself? And the answer to that question is, what does the test manual say? What is a standardized administration? And if you're deviating from the standardized administration, you're introducing error, some unknown amount of error variance into the results. And it's up to you to decide, is that too much error variance such that it's going to not be useful? Or if you are going to rely upon it, it's going to be up to you to justify that and appropriately caveat your opinions that derive from doing that.
And one more quick thing I just want to throw out there, that APA did develop some guidance on psychological teleassessments recently, just related to this situation, and it's very much aimed towards the COVID situation, so that can be helpful as well. There's I believe 6 guidelines that outline a lot of what we've already covered here, but that's for just assessments in general, not just forensics.
Great. Okay, so this is a question we get a lot, and there may be a lot of state-specific answers here. So of course we can't address that, but if you guys can just talk to generally how would one start to think through this issue, and it's of course the issue of interjurisdictional telehealth practice. So here's the question: can you please provide an update regarding telehealth laws across states, particularly whether we can see our clients via telehealth who are now unexpectedly residing temporarily in another state with family or for other reasons due to the COVID-19 crisis? Julie, you want to start?
Sure, I'll jump in. It's an excellent question, and there are some resources. There are several web pages trying to keep up with all of these changes. ASPPB has put out a living document. They're updating it, I think, at least daily, trying to keep up with all the different executive orders, all the different waivers. You can go through the list state by state, and they have some live links in there that you can look at. So your first step is to try to see if you can decipher that and figure out if there is a waiver that's going to allow you to provide that service. That's kind of the legal piece. But you also want to consider the ethical and clinical considerations. And so if it's not clear that how if there's a waiver or an application process, but you feel like you have a patient who's an ongoing client who needs care, and continuity of care and avoiding harm and avoiding abandonment is your paramount concern, then you do the best you can. You make a good faith effort to comply with the laws of the state where the patient is located. That's where the service is considered to be provided. Like we've noted, many states do have waivers or have already in place temporary practice provisions that would allow you to practice into that state, even pre-COVID. So some states have expanded those time limits and allowed you to do that. Like so many things we're talking about today, documenting why you're doing what you're doing, documenting that you understand that there are limits to interjurisdictional practice. If you've taken steps to notify the state where the patient's located that you're going to be practicing there. Some states are asking you to email the board and give them your name and license number. document your good faith efforts to comply with those laws, and then document the reasons that you believe it's appropriate and important for you to continue to provide services, to avoid abandoning someone when clearly they are under a higher level of stress. I think we all are. So, you do always need to consider the legal piece. And as Joe mentioned earlier, there is a remote small chance that there could be some sort of criminal charge against you for unlicensed practice. But if you're making a good faith effort to do the best you can by your patient and you're documenting that, it's hard for us to imagine, or it's hard for me to imagine a board sanctioning someone or coming down really hard on them in such extraordinary circumstances.
Right. Yeah, I would agree with all that. And if I had a patient who is now suddenly in a different state, this is the process I'd follow. I would go to there's maybe 5 or 6 websites, and you'll find the links to those websites on our website, trustinsurance.com. Click on the COVID resources and look through those links, and you will see under interjurisdictional practice, there's about 5 links or 6 links to different websites that are tracking the waivers in all the various states, all 50 states. So you can use those links to figure out what's going on in the state where your patient is now located at. And you may find that it's very easy to obtain temporary practice privileges. For example, New Jersey simply requires you to fax in or email in a form with a description of your credentials, and within 24 hours, it's returning a temporary license to folks who have a license in another state. And so there are other states that are doing similar things. So the first thing you want to do is find out, can I legitimately practice in the state where my patient is now located at? And you do that by checking for the waivers in that state. If their waiver doesn't apply, the COVID waiver, then you may look to the temporary practice provisions that every state has had on their books for years. Every state has some form of temporary practice provision, and that may give you the ability to practice at least for a while in that new state. The worst case scenario is that there's no COVID waiver that allows you to practice and see that patient in that other state, and there's no temporary practice provision that you can use to get into that other state. Then you have a dilemma. Then you're going to have to do the cost balance analysis that Julie was speaking about, and that I need to continue to try to maintain my patient and help them, and yet I'm going to be in violation potentially of the rule. And I need to balance those things. I need to show my reasoning, and I need to practice at the highest level I can. And I suspect that the people are not going to use this time to go after clinicians. I think that most people are going to understand, and there is a relaxed regulatory environment, at least for now.
Great. And somewhat related to that, what about the question as to whether the trust coverage or liability coverage will cover you for telepsychology into another state or cross jurisdictions? Julie, you want to? Or Joe, either one.
Well, I think we kind of addressed that before.
This is specific to the if it's across jurisdiction. Is the coverage still covered?
Correct. Right. Yeah. So telepsychology is covered under your policy, as I said, as any active psychology is in your policy. When you go into another state, should you get a board complaint or malpractice suit from your work in that state because you are not licensed, you would, or if some other reason, your policy would defend you against board complaints and malpractice suits, even if they arise from work you're doing in a state where you're not licensed. The problem would arise if you were the state that is where you're not licensed decided to charge you with unlicensed practice of a profession, which is really the only option they have. And in that case, that would be a criminal charge. And as I said, no professional liability insurer can insure against criminal risks. It's prohibited. So, but the reality of that happening is extremely small. To the best of our knowledge, no state board has gone after a psychologist criminally, as far as we know, for videoing and phoning in to that state. So the risk is quite small statistically, and I think during this particular environment, the risk is going to be even lower. By the way, I think we may have lost Julie. Liesl,
Oh.
I just want to, it looks like she's frozen.
Julie, are you available? Yeah, we might have. It does look like she's frozen. Okay. So we can, well, while we're managing that tech, let me just put another question to you, Joe, then. This one says, I'd like help coming up with a robust plan for if a client communicates suicidal intent via telepsychology, both voluntary and involuntary hospitalization procedures. In essence, how do I handle that if a client is disclosing suicidal intent via telepsych?
Well, I mean, to some degree, you would do the same thing you would do with any patient who begins to express suicidal ideation. The very first thing you want to do is to conduct a comprehensive assessment of that risk. So you could use a structured instrument like the Columbia Suicide Severity Rating Scale or other instruments that would allow you to quantify the intensity of the suicidality of your client. So you want to do that. Even if it's by tele means, you can ask the questions on the instrument and score the person. Once you have a sense of how suicidal they are, where they fall on the continuum, that's going to dictate your next moves. If the risk is manageable or there are interventions that can reduce it, then that will be your treatment plan. If it looks as though the risk is very high, then you're going to have to start looking around for some potential third parties that may need to intervene. So the first thing is a comprehensive assessment. Second would be a plan that derives from that assessment. And in a telehealth situation, I think I would try to provide the clients with resources in advance. Say, for example, a sheet with phone numbers for their local hospital, mobile crisis numbers. I would try to identify as many resources as I can that are available now and be ready to give them to any client that I see via telemeans so that they have something they can hold on to that has some set of resources available to them. So I don't think it's that different from dealing with suicidal patients face to face. It's just going to be more challenging to identify resources and third-party interveners that can intervene if it becomes necessary to do so.
Great. So why don't I step in and pose the next question to both of you, all right?
Okay.
Sounds good.
All right. So do you have any suggestions for documentation when sessions are performed via telehealth? Specifically, dictated notes for services provided via telehealth to hospitalized patients.
I'm not sure I understand that part of the question, Jana.
Okay, well, I didn't write it, so my guess is, what about let's just handling the first part of the question. Suggestions for documentation when sessions are performed via telehealth. For example, is there any difference when you're doing telehealth versus in-person sessions in terms of documentation?
Well, I'll take an initial stab and then Joe, you can jump in. But I mean, I think the largest difference is what maybe was touched on just a little bit before. I mean, you do want to include additional things, right? Like you want to document where is the person, you know, those kinds of things. So there's additional pieces that you need to add into your documentation, but the clinical note itself is going to be much the same as you would with the in-person piece.
Right, I agree with that. And I think the only special steps I might take for documenting teletherapy sessions is whether if there were any issues with the teletherapy itself and to what degree that seemed to impede the session. If there was a lot of jumpiness and lack of clarity, it would be important to note that in your notes in case there's something that you missed as a result of that. So anything that pertains to the technology and that goes wrong with it or that adds a wrinkle, that probably should be documented in addition to what you would normally document. And as Liesl was saying, it's important to get basic information as to where the client is, to get a phone number that you can reach them, where they are at that moment. And I think you may want to give them your phone number or a place they can contact you in case something goes wrong at their end as well. and also document their environment, where they're at and who's around them, and so on.
All right. I know high-risk patients are not generally suitable for teletherapy, but I don't have any other options right now. Do I need to refer them out? What if I can't find anyone providing in-person services in my area?
Mhm. Yeah, so I mean, I think again, we're going to start repeating ourselves a little bit, but I mean, ultimately, you're going to have to make the best clinical decision you can, right? It's a cost risk benefit analysis, and if there's no other option, it may be that this, you know, and especially if it's an ongoing client, it may be that you would prefer to have them in some other care, but you may need to do something temporarily. You know, and again, the issue is that you would document what you're doing and why. Why did you decide either to continue in this format? If that's your decision, what, you know, what were the risks that you saw? How do you think you can mediate that, document that, and so forth? And then in the other direction as well, if you think you can't do it, that in fact the risk is too great, you'd have to document that as well. So it's really an issue of, you know, again, doing the cost risk benefit analysis and making the best decision we can in a not perfect or ideal world at the moment.
Yeah, I mean, unfortunately, there are no good alternatives that I can think of for a patient who needs face-to-face contact, let's say, or needs a program where there's multiple people going to be around them during the program time. I don't really, honestly don't know whether those programs are still running or how they're running. But what's for sure is that that whole slice of resources is either limited or not existent at this point. And so we just don't have a lot of choices. It's either going to be teletherapy, phone therapy, some kind of remote contact, or it's going to be a referral to the hospital or to some place that's prepared to treat people face to face, like a hospital. So those are the only real options that I see. And like Liesl was saying, it's important to document that reality. But I don't have any good answers here other than to try to be as creative as you can to find some way to maintain a clinical bond with your patient.
You know, all of you have said today that it is difficult sometimes to answer these questions. And I think it should be somewhat comforting to our listeners that sometimes there are no perfect or right answers. And if you do consultation, you document your thought process, all the things that we've talked about so far today, sometimes that's the best thing you can do. So try not to get discouraged. Here's another question. What about our responsibilities to not abandon a client if insurance all of a sudden will not cover the way you're providing services?
Yeah, I can take that. The good part, if there is any good part of this, is that states are increasingly recognizing the value and importance of teletherapy, as are insurance companies. So I think what will come out of this at the end, hopefully, is a much more equal standing for teletherapy and protections for reimbursement and things that will make it easier to do teletherapy. Most states, as I said, do make teletherapy the equivalent of face-to-face sessions and require insurance companies to reimburse. If it ends up that for whatever reason you're at the end of all this that you can't do that, then I think you're going to have to do what you always do with a patient where you're not sure you can continue, which is to discuss the options that are available, to refer them to someone else that may be able to meet their needs, or try to find some accommodation that will work for them and you. But I don't think the situation would be any different if it was a non-telehealth reason for the change. You would have to try to work out a plan, and if that doesn't work, you'd refer the patient.
Okay. What about a situation where you agree to care for a client of a colleague who is not doing teletherapy? in terms of what types of forms are needed, what do you recommend, how do you facilitate transition?
Well, I mean, that's going to be much the same as you would facilitate transition, again, outside of COVID. I mean, if a colleague were referring a patient to you or we're going to transfer care for whatever reason because they couldn't continue it, I would handle it much the same way. You'd want to get, updated intake paperwork from the patient. You should do your own assessment. Of course, you can, get the patient to sign a release of information and get the records from the prior clinician and or have a conversation with that clinician. But in terms of, documentation and the general transfer, I think a lot of that is going to be very much the same. Although I guess the big difference is that with everyone doing telehealth now, you'd be adding in the telehealth piece and making sure that the person understands, how to do the technology platform that you're using and those kinds of things.
My thought is that if you're filling in for a colleague or you're trying to help out a colleague who can't do telehealth with their clients, if you're a separate practice, you don't have a right of access and that other therapist shouldn't give you access to their PHI unless they've made some arrangement with their patient to allow you to step in with the patient's consent. And I think there should be some plan. Is it going to be a temporary situation where you're filling in for your colleague who can't do teletherapy, or is this going to be a potentially a transfer to you permanently? So there should be a discussion between you and the person you're helping as to what you're trying to achieve, and that patient should be involved in that discussion so that they know I'm getting a fill-in therapist. I'm going to consent to information being transferred to the fill-in therapist so the therapist knows something about me. Or am I terminating with my therapist, my regular therapist, for a while and becoming a new patient of the fill-in therapist? So that conversation and that decision needs to be made clear and documented, and the patient should be involved in that process.
I agree with that. Just to clarify, I was assuming that it was the transfer. So if it's not, I just want to say I agree with Joe.
Okay. So here's a little bit of a different slant regarding HIPAA enforcement. If we don't have a secure patient portal, can we use scanning and email to have consents signed during this period of relaxed HIPAA enforcement?
Lisa, would you like me to try that, or?
Sure, go for it.
Yeah, the HIPAA has really relaxed enforcement of its rules regarding use of teletherapy platforms. It's the saying HHS, the entity that administers HIPAA, has issued guidance that you can find on their website, hhs.gov, and you would look for HIPAA and COVID. HIPAA has relaxed its enforcement during the crisis so that if you use a non-secure platform, as long as it's not what's called public facing, meaning it's not like straight Facebook or something that's meant to involve third parties, but is rather a technology that allows one-on-one contact. HHS has said that we will not enforce any violations during the COVID crisis for that kind of relaxed security. So you can rest easy for that for now during this crisis.
All right. What concerns must be considered if a group of mental health providers want to provide pro bono sessions to anxious community members? Don't have any takers on that one?
Seem to not. I don't know if you guys hear me, but I can't hear you guys at all.
Oh, okay. Joe, can you hear me?
Yes, I can hear you.
Okay.
The question with pro bono, whether the issue of doing pro bono services during this time, I think, with anxious people.
What concerns should folks have about providing pro bono services?
It's probably wisest to assume that there's risk in any clinical professional work you do, and that the pro bono is not going to remove the risk of board complaints or malpractice suits that come from that work. Now, there is a possibility that there is some protection during this emergency. Some states have kind of made it more difficult to complain, or they protect practitioners from malpractice suits. But I personally don't think it's wise to rely on that. I think that even if it's pro bono and you're volunteering, it would be best to try to maintain the same standards of professionalism and security and confidentiality as you would if you were getting paid. So there's a chance that there is some statutory protection because you're volunteering, depending on the state. But as I said, I would not count on that, and just continue to maintain the high standard that you usually maintain.
Great, thank you. I don't know, Liesl, if you can hear us yet.
I think I'm back, yes.
Okay,
Sorry.
good. Did you have anything you wanted to add?
No, thanks.
Okay. Well, we are coming to the end of our time. I want to say a few things to answer some questions that have to do with some housekeeping issues. Before signing off this presentation, please complete the evaluation in order to receive your CE certificate by clicking on the link that will be provided in a few minutes on a slide. Your CE certificate will be sent to you via email upon completion. We want to thank you for joining us today, and we ask that you please check our website for the schedule for our next Risk Management Roundtable. There are also numerous resources under our tab COVID Resources, including the informed consent for telepsychology that many of you asked about. I also want to add that the Trust, in conjunction with the National Register, last Tuesday the 14th, presented a webinar on doing neuropsychological assessments during the pandemic. That video, which is a 1-hour webinar with slides, is available or will be available in about 5 or 6 days on both the National Register website and the Trust website. So again, keep checking back for resources. I know there were many people who had a lot of assessment and specifically neuropsychological assessment questions, and this was a splendid presentation that included 3 renowned neuropsychologists and our own Dan Taub as a risk manager. So again, before you cut off from the webinar, you need to wait, click on the link for you to complete an evaluation so that you then can be sent your CE certificate via email. Thank you again, and we'll see you at the next chat.